And why don't we get started? So hi, everyone, and welcome to the U54 Partnership Research Design and Analysis Core Spring Seminar. And I decided it's our spring seminar because it's March 1st, and I know we have more weather ahead of us, but I feel like we're closer to spring today than we were yesterday for some reason. So this is our spring seminar. All of you know on the call, but for the purposes of recording it, I'm Carol Lowenstein, Director of the Research Design and Analysis Core, which we refer to as the RDAC, and I'll be moderating today's seminar. As many of you know, we hold a number of seminars primarily scheduled during the academic year. We aim to highlight topics that are methods focused, as well as provide tools that assist in research that's being conducted throughout the partnership. Each seminar is recorded and posted on the partnership website. If you haven't had a chance, at some point, please do take a look at the past seminars and feel free to reach out to presenters with questions. They're more than willing to answer questions at any time via email or get in contact with folks and set up a meeting. Everyone's more than happy to give advice, ideas for future research, help with collaboration, etc. I think, as is evident throughout the partnership, people are there to help. In terms of housekeeping today, I'll monitor the chat if questions come up, and I'll pause intermittently to see if there are any questions as we go along. I know our speaker today very well, having worked with her at the Massachusetts State Cancer Registry a number of years ago. So my youngest he just turned 24. Had to think about that. And I left just before I had him. So it's been a while. Oh, Andrew Hantel is looking for the thing. Ruth, can you send Andrew Hantel the link? Yeah. Thanks. Dr. Susan Gershman has a BA in biology from Wheaton College, an MS in education from Southern Connecticut State University, an MPH in health services administration from Yale University, and a PhD in cancer and environmental epidemiology from the University of Pennsylvania. She's also a certified tumor registrar. Many of you might not know that that's actually something that is out there, and people do get certified as tumor registrars to collect this data. Dr. Gershman has been the director of the Massachusetts Cancer Registry, which is housed in the Massachusetts Department of Public Health. She's been the director since 1990. She served on the board of directors of the North American Association of Central Cancer Registries, NACER, for 12 years. And I'll just say that was at a very key time for that organization because it was still really forming and gaining the strength that it has today. She served as president and treasurer. In 2011, she was recognized by Massachusetts General Hospital as one of 100 individuals and organizations leading the fight against cancer. This past June, she received NACER's Callum S. Muir Memorial Award for her many years of service and leadership to the cancer surveillance community and NACER, including board member, treasurer, and president, and for her unwavering commitment to the establishment of interstate data exchange. Susan, I will turn it over to you.
Okay, thank you for that too long introduction, but yeah, it's been a long time. And I think what I'm gonna do, see if this works, like a slideshow, is that okay, or is that?
Yep. No, that's great.
And I think my page down. Okay, I just have to, I'm sometimes technically challenged. So thank you for inviting me today to present on the Massachusetts Cancer Registry, which has changed a lot since the 90s. So my presentation is divided into 6 components: cancer surveillance, organizational structure, updated legislation, operations, epi and data use, and how to access our data. And you can stop me at any time, and maybe just before epi and data use, I'll pause in case there are any questions. So I always like to start to remind us all the definition of surveillance. Public health surveillance is the ongoing and systematic collection, analysis, and interpretation of health data to describe and monitor a health event. And so the health department has many surveillance systems, such as HIV/AIDS, birth defects, COVID, etc. And we have fundamental requirements of registries that I always like to remind myself. Above all, we must protect the confidentiality of those that are reported to the registry, because we collect PII, etc. We want 100% registration, most likely not possible, but yeah, we have to try to get there. We want to prevent duplication. We want uniform standards. We want high quality data, efficient data processing. And of course, we want to be able to analyze our data and report it out to our citizens. Now, I'm assuming you recognize this actor, John Travolta. He starred in the 1995 film A Civil Action, and it was based on a book written by Jonathan Harr, and it dramatized a late 1970s purported childhood leukemia cluster in the small town of Woburn, Massachusetts. I mean, you might have heard about it. It was pretty big news, I guess, at the time. I mean, I wasn't there. And this was actually the impetus for the establishment of the Massachusetts Cancer Registry. They were actually knocking on doors to try to find childhood leukemia cases. If they had had a central cancer registry, they could have just went to one door. And, personally, I like them better in Saturday Night Fever, but so it is. Yeah, staying alive, right? When I'm driving the Mass Pike. So the registry was established in 1980 by law. And in 1982, they began case reporting. And at that time, I think there were maybe, well, I wasn't there, but I've of course seen the forum. Maybe there were 25 fields, maybe 40. We collect 832. So things have now, with I think about 2,000 edits, so definitely changed. I'll skip over to 1994, and that's when we received funding from the federal government, the Centers for Disease Control National Program of Cancer Registries, and it was really at Vermont Senator Bernie Sanders who established a public law. I think it's Public Law 102.515, because there were so many states that didn't have cancer registries. And 2004, we actually changed the law, which is pretty short. It's the regulations, of course, that are much longer. And we added benign brain-related tumors and a staging system called Collaborative Stage, which actually isn't used anymore. And in 2018, we received federal funding from the National Cancer Institute Surveillance, Epidemiology, and Results program. So we're now what they call a dual funded registry. And we are 80% funded by the federal government. Now, let's see. So one of the strengths that I think for cancer surveillance is there are multiple national organizations, but not only CDC and NCI, but Commission on Cancer of the American College of Surgeons, because they have an approvals program for hospital cancer programs. And I would say maybe 60 or 65% of the data that we receive comes from hospitals that are part of the COC. Also, as Carol mentioned, the North American Association of Central Cancer Registries, an umbrella organization that focuses on education, setting standards and data use, the National Cancer Registrars Association, and they run the certification program that's called CTR, but that's going to change in the next 6 months. It's going to have a new title, and they're not telling anyone what the title is. But, and also American Cancer Society. So the organizational structure, the health department, it's always bureaucratic. So we're on the right, and our main divisions or units or operations, IT, geocoding, and epidemiology. Now I'll move on to legislation. So this is our law, Massachusetts General Law, Chapter 111, Section 111B, malignant disease and benign brain-related tumor registry, and we do have regulations. So this is what the regulations do. They describe cases of cancer and benign brain-related tumor disease that are required to be reported, specify who is supposed to report, what information is required to be reported, require access by the cancer registry of patient medical records necessary to verify the accuracy of reported information. And we did this because NCICR likes to do linkages in the background, and they're now doing some pharmacy linkages. So this gives us the ability, if we need to do some quality control efforts, to go to pharmacies. But we're not required. Okay. Somehow I'm getting a feedback, but okay. So also confidentiality. And it was just about a year ago that we promulgated new regulations, and it was a 2-year process, and COVID probably didn't help the length of that, but we had to meet with the commissioner, our lawyers, of course. We had to have a public hearing. It had to be approved by the Public Health Council and finally promulgated just about a year ago. So our operations. This is, I believe, the third database system as part of the NCICR contract. And it's different from CDC. CDC is a cooperative agreement. They just, give you the money. Of course, you have to write a budget, but CIR is a contract. You actually have to have money available to pay your staff, and then they're invoiced. So it's a little bit more complicated, but as part of that contract, we had to migrate to a new database system called CRDMS. It's an amazing system. It has all these bells and whistles, but for staff that for 20 years have been using our old system that was designed in-house, it's a big change and not easy to get used to. So presently, we have 61 hospitals, which is interesting since when I started, there were 122. So there have been a lot of mergers and closures, etc. We also had to move to some non-hospital reporting, and we were getting these paper, which is just, I guess, somewhat of a disaster, because you can imagine paper records, about 7,000. And we had a closet which is locked because paperwork takes a lot of staff effort. They have to be scanned, uploaded, then shredded. So we are now moving. Hopefully, we're going to be over the highway. It just started with a letter to a couple of our non-hospital reporters a couple of weeks ago. So we're pretty excited about that. It will be PDF and webmail. And we do get all our hospital data. It's all electronic. We also link to the death file because there are missed cases, and we have to identify them through the death file, and they're called death certificate only cases, and you have to keep that number below a certain percentage. For NCI, it's actually 1.5%. So we're not there yet. We have data exchange, so we exchange with 44 other states, and there's still 5 states that won't sign. We're not sure why. I think it has to do with their government. District of Columbia, 3 unincorporated territories, Guam, Virgin Islands, and just recently we're data exchanging with Bermuda. We follow uniform standards, and it's NACER data standards and data dictionary. And as I mentioned, approximately 832 fields, and I've provided the link. So what do we collect? Patient information, tumor and staging, biomolecular factors, more and more, treatment data and follow-up information, which is new with SEER DMS. Or just being part of the SEER program. So our patient information is facility and physician information, identifying PII, name, address, date of birth. We do collect Social Security, and we do a lot of searching to try to make sure that we can get that, because it's really important when you're trying to link data. Our demographics, sex, race, ethnicity, marital status, birthplace, and occupation and industry. Tumor and staging data. So for tumor data, primary site, histology, grade, laterality, date of diagnosis, date of first contact, staging data, size, lymph nodes, metastases, site-specific factors. Each cancer, not all of them, but set cancers have site-specific factors. First course of treatment, surgery, radiation, systemic therapy, chemo, hormonal, and immunotherapy. And we do collect follow-up. We're trying to focus more on that because it's part of our SEER contract. So it's date of last contact, vital status, and cause of death. So our focus is on timeliness of reporting, completeness of reporting, and a high quality data. For Massachusetts, about 95% of our cases come from hospitals, which would be different than a state like Texas, which has huge area, many more centers where they receive care, versus Massachusetts, kind of a medical mecca. Not that hard to reach, difficult to reach hospitals. And as I mentioned, we do link to death certificates, and we've been below 3%, but we need to head even lower for our DC only cases. So hospitals are required to report 180 days after diagnosis, about 6 months, or date of first contact, whichever is first. So this is not that easy to achieve, and I would say probably it's more like an average of a year. And we do have some delinquent hospitals that, when we're submitting our calls for data that occur in November, December, we have 3 calls for data. And actually we just had, those are our big calls for data, but then we have another call for data, which is considered like 12 months. And that would be which is 2021. So that was just due. So we want timely reporting, but I think our federal funders are definitely working on some way to probably it's the amount of fields, that 832 fields. So thinking about maybe having less fields so we can get our data out more timely. And there's a lot of data quality, as I mentioned, about 2,000 edits. We have visual manual review. We have audits, our own audits, but also CDC and NCI have audits. And I think we may be the only state that releases data on a city-town level. So we do a lot of geographic QA. So NACER runs a certification program, and I think it might be the only surveillance system that does this. And these are the standards that we have to meet. We have to have, for gold certification, 95% of our cases. So our next certification would be for 2020 data. Now 2020 data is going to be an interesting issue because it was during COVID, and a lot of states are reporting fewer cases. So there's going to be an adjustment by, I think, CDC, NCI, and NACER. We have to have certain critical fields such as age at diagnosis, sex, race, county, less than a certain percentage of unknown. So you can see 2% for age, sex, and race, and 3% for race, 2% for county. We have to keep our death certificate only cases below 3%. We collect admissions, so we have to work very hard on deduping our file. We have to pass edits, and the data has to be submitted within 23 months. So for 22 years, we received gold certificates. So really exciting for us. But last year we had a big issue with our death clearance process. So we only received silver, and we had to do our death certificate follow back outside, and even linkage outside of our new database. But this will be changing over the next year or two. So I guess I can pause if there are any questions, and then before I move on to epidemiology and data use.
Susan, I had two quick questions. One of them is to increase the time lag in getting cases in. Is there been any thought about like a two-stage process where you could at least get the demographic information in, or what's going to be most useful to people, and then follow up with the other,
Yep.
750 fields that are maybe less used?
Yes, definitely. And New Hampshire does that, but you have to consider that New Hampshire, our paper records are maybe what New Hampshire receives for cases, because their population is so much smaller. Yes, so they have a two-tiered process. They get some basic information like critical fields, and then later they add to those data fields. But for New Hampshire, I think they're, I don't know, is their population like 1.5 million or something like that? So they would get, what, a fifth or a sixth of the cases. Massachusetts is now 7 million. But it's just at a meeting the other day, and NCI was talking about that type of model. But when you think of some states like New York and California and Texas, I mean, we get 67, well, in the 60s, maybe, I think last year, maybe it was 61,000 admissions. So you can imagine what their numbers look like. So much easier for smaller states, but definitely, because we feel we need to be more timely with our data.
Thanks. And then the other one is the biomolecular factors. Could you just give us a couple examples of what those are?
Oh, well, I'm not the best on that because it's by site. Oh, so maybe, so for breast cancer, it would be here. We believe we caught BRCA 1 and 2. I'm not super positive. But like estrogen positive, negative, so we, triple negative, etc. So we can identify that. But there are a lot of other specific ones, and also in the background, NCI links to, I have a list somewhere. I could look it up. I was just reading a paper about it, and they do it in the background. And the companies are Oncotype, DX, Decipher for prostate, Precision for melanoma. So there's a lot that goes on in the background.
Okay, thanks. Yeah, that might be of interest to some of the folks who are doing research in the academic world.
And it's the 50th anniversary of NCI SEER. So I was just reviewing that paper, and that's why this is happening in the background, and I really need to get a more understanding of what they're doing. I don't really know how they're using the data, or it's almost a field that is not being, so it's not being transmitted to us via the hospitals. It's what SEER does a lot of linkages. There's also a National Childhood Cancer Registry that they've created. I think 27 states are participating, the SEER states, and a few other states that are funded by the National Program of Cancer Registries.
Great, thank you.
All right, well, I can move on to EPI and data use. So as I mentioned, the Massachusetts, it's growing. It's now at 7 million for 2020 admissions. It was 61,000, which is lower than usual. Usually we have, I think, close to 67,000. But we have to take, this is the complexity, I think, definitely for cancer data, that you can have multiple tumors and you could be admitted to 10 hospitals, and we should be getting all those reports. So we have to take all that data and put it together, because when we report for our calls for data, it's only per tumor, it's only, one record. So with the 61,000, we ended up with 40,408 for 2020, and in situ 2,655. And Massachusetts is becoming more diverse. So 70% white non-Hispanic, 7.5% Black non-Hispanic, 7.4% Asian non-Hispanic, 12.8% Hispanic, and 2% other, such as could be Native Americans. And how are our data used? Ongoing surveillance of cancer incidence and trends, program development and evaluation. We work very closely with our Bureau of Environmental Health. They're responsible for community assessments like Woburn and the civil action case, public health information and professional education, epi and biomolecular research. So we do have standard reports. And we've taken some of the older ones off, but we do have, I believe, back to 2017. We just released 2014 to 2018. Usually these reports provide 23 sites. We have age-adjusted rates, age-specific rates by race, ethnicity. The latest report through 2018 has a focus on health equity, and in progress is our 2015 to 2019 statewide report. With our move to this new database system, everything was delayed. So we applied for this SEER grant in 2017. We were funded in 2018. It took almost a year and a half to sign the agreement to transfer our data to the new database system, SEER DMS. And we migrated in the middle of COVID in the fall of 2020. We didn't even have state laptops, so most people didn't have access. It has such security requirements to the new database system. So we would have training, but our operations staff couldn't really practice. So somewhat delayed with the learning curve. We do special reports. We had a race ethnicity report in 2015. We had a grant with a former commissioner, was working with a colorectal cancer coalition. So we produced a data report and a fact sheet on colorectal cancer. We just released about 2 weeks ago a childhood adolescent cancer in Massachusetts. That's our third report, and the URL for our reports. So what are we working on now? A COVID-19 linkage. has been completed. We worked with our Bureau of Laboratory Sciences, and I just submitted it as an abstract to the NACER conference, which will be held in June. We have a prostate cancer data brief that's under review, a liver cancer data brief, and we are trying to modernize our city town report to incorporate it into a piece of software. I'm not sure if you all would be familiar with environmental public health tracking, but I have a link to that at the end. We do a lot of linkages, and it seems that epidemiology has changed. It's not case control studies. Everything seems to be cohort studies, these cohorts that are linked. And you'll see that in some of my listing here, like the World Trade Center Registry. Every year we link to follow up on those that were exposed to the chemicals environment from 9/11. We do link, as I mentioned, to the mass vital records, the National Death Index. We work with a group on ART, assisted reproductive technology. Also, two HMO groups as part of the Cancer CRN, an NCI-funded initiative to support and facilitate cancer research. We've linked to prisoner data. We've linked to a homeless population at Mass General. We also link to some of our own programs that do screening for like lung, breast, colon, and cervix. We were also involved in an NCI-sponsored HIV/AIDS and cancer research, ecological analysis of PFAS and public water supplies, and we linked to all payers claims database. So Massachusetts is one of, I believe, 18 states, there aren't many, that have these databases. So it was a huge linkage, and we did have one publication. NACER is also working with NCI. Well, NCI funds the virtual pooled registry, and NACER is the administrator. So these are a number of matches that we've done: the NIH ARP nutrition study, military aviators, community-based cohort study of disease occurrence in Ohio and West Virginia, NYU School of Medicine Women's Health Study, the Sister Study, which is a breast cancer study, and the Black Women's Health Study. And one of our future matches, we're working with a researcher from Beth Israel at Harvard on a financial toxicity and thyroid cancer study. So this link would be to Experian, which is kind of like TransUnion credit holder, credit information. These are just some of our recent journal articles regarding the birth defects and cancer risk in children, which I mentioned, and the all payer claims data was that database didn't have Medicare data. So the researchers did publish a study regarding BRCA 1-2 testing among young women with breast cancer. And there was a prostate cancer, differences in the treatment and outcomes of prostate cancer. So we do quite a bit of research. And how do you get our data? So you can see there are numerous data query systems. The first one is, we call it our data query system, but in fact, it really isn't ours. It was designed and developed at the University of Kentucky, and we pay them a small fee. It's like $6,000 a year. And we send them our incidence and mortality data, which they load. It's pretty user-friendly, and it has mapping, tables, graphs. Our data are also in the CDC, USCS data visualizations, NCI SEERStat, cancer incidence in North America, CINA Explorer, CINA Map, CDC Wonder, NCI state cancer profiles. Yeah, we're in a lot of databases, including Massachusetts has a new database system, and our data are old in this one, but it's going to be updated. I think probably to be the next 6 months or so. But if you're in the process of thinking about a study, I don't know, would be a good example. Use let's see, smoking and lung cancer. Okay, so, and you want to use our data, you would go to the URL that I've listed first, which gives you information on how to apply for access to our confidential records data, not only the cancer registry, but other databases also. We're actually in IRBnet, which is, I think, excellent. It's very organized. And so the researcher would just fill out the application, submit it, and then it's reviewed. When you log into IRBnet, you have to affiliate with the Massachusetts Department of Public Health. You need IRB approval from your sponsoring institution. It says if applicable, but most of what I've reviewed has had IRB, or you might have exemption. There's a core application, which includes a project narrative, as well as what data fields you want. You have to provide a data storage plan, and it's reviewed by the Massachusetts Department of Public Health's oversight or full IRB committee. And then you would receive a modifications decision letter. I believe you have to sign the, I think you have to sign the letter. You might have to sign a confidentiality pledge, et cetera. You know, it really depends on the study, because they do vary. For sure. I mean, not too long ago, we were helping out a researcher at Dana-Farber, where we write a letter about the study. It's just a one-page letter, right? And I sign it. And then it's sent out to whatever, say, prostate cancer cases. And they're given a brochure about the study, and they would just contact the researcher if they're interested. And I think from what I've heard, they've had great success, because the last researcher just asked if we would help them out with 2 or 3 more studies. So that's kind of great news. You can also get data from NACER. And as I mentioned, there's CINA Explorer. So you have to just go online and I don't know. I was online just trying to figure out if I wanted a table or what cancer, et cetera. It's pretty easy. There's also CINA Maps, and that's pretty new. They also have a public use data set, and I believe you have to sign a data assurance agreement, and the data are released via CIRSTAT. And again, all that information is online. They also have a research data set. And with that, I believe you have to have someone from the NACER community, probably a registry director, co-sign. And they have groups, work groups and task force that review these data. And again, they're released via CIRSTAT and might require a CIR institutional account. But all this information, again, is on the NACER website. Now, for the research data set, it would be under CINA Research. The other software is NCI CIRSTAT software. It's a statistical software that calculates raw data of cancer rates, rates and trends. You can use CIRSTAT with CIR research data, and it's not that easy to get access actually, and I still don't have it, although 2 of our epidemiologists do, because you have to use some of the government sign-ons like ERA Commons, and I've had issues with that. So one of these days I have to get back to that when I have some free time. But CIRSTAT gives you frequency and rates, such as crude rates, age-adjusted rates. They also have a process that they call delay-adjusted incidence rates. You can get survival statistics, and they have a lot of information on the CIRSTAT or the NCI CIR website, tutorials, installation, and so the URL is below. This is our website information, our latest report, also the Massachusetts Environmental Public Health Tracking Program. And we always have to acknowledge support from our funders. And as I mentioned, we're 80% funded by CDC and NCI. And I always like to think about this quote from former President Barack Obama: "For the loved ones we've all lost, for the family we can still save, let's make America the country that cures cancer once and for all." And I know that President Biden now has new initiatives regarding the moonshot. And I always like to end with, at least for me and my NACER colleagues, we don't just talk the talk, but we walk the walk. And every year we try to get together from all over the country, Texas, Kentucky, Chicago, etc., to walk the Jimmy Fun Walk. And we usually do a half a marathon. So with that, I will end my presentation.
Thank you, Susan. That was wonderful. And that was a wealth of information. Brett, I see you have your hand raised in just a sec. I did want to mention that we'll also post the slides along with the recording on the partnership website, if that's okay with you, Susan.
Yeah, I'll give you an updated. I made a couple of changes.
Okay, great.
Grammar, etc.
And that way, folks can access the links, and then I'll have a copy too if people want to reach out to me. Brett, did you want to unmute and ask your question?
Actually, those were applauding hands, but I will ask a question. I was actually really struck by the comment you made about there's been this real shift to sort of cohort monitoring.
Yeah,
yeah. I was wondering if you could speak a little bit for that and how you see that sort of changing the sort of landscape now that we're sort of thinking in cohorts rather than how they thought about it sort of previously.
Well, I guess I just think about what I did for my doctoral dissertation. It was a case control study of DES and testicular cancer. So it's really labor intensive. So you have to, I had a questionnaire, I had to locate the cases, etc. Now it seems that it's cohorts, whether it be, the aviators or a cohort of prisoners or the homeless, or we do the firefighters from 9/11. And that's why NCI established the virtual pooled registry, because they were envisioning it's going to be huge. And they're pretty interesting. There's one that it's in North Carolina, Camp Lejeune. I don't know if anyone's ever seen the advertisements regarding Camp Lejeune and their lawyers, the ambulance chasers, I guess, which is pretty interesting. And I believe, the cancer registries were involved in the chemical associations with, I'm not sure exactly what it was, but we do so many of them. But I looked back and sure enough, I saw that I think it was once part of the virtual pooled registry. So what the virtual pooled registry does, it will have a cohort, and there was a radiology technicians cohort, and as another example. And so you link, and it's all very well organized by NCI and their contractor IMS. And we'll just give them a number, like how many linked, and maybe we'll say 100. And then they take that back to the researcher. If the researcher thinks it's worth further follow-up, they'll come back to us, and then they'll have to do more, like an IRB, etc. And, maybe it's like, say, Utah, 2 cases. No, we're not, I don't mean to use, no reason, but I'm just using Utah as an example. Okay, we won't follow back with Utah, but Massachusetts has 100 cases. So we want more information about those cases so we could look at cancer incidence for our cohort.
Susan, could you also talk about the lowest geographic area that one can get?
Oh, you can. Well,
Smallest.
we do census tract and block. But a lot of that has data suppression rules. So you might have to increase the number of years. We do release a city town report, and we do standardized incidence ratios and indirect method of standardization. And if the number of cases over a 5-year period is less than 5, we don't calculate the SIR.
Thank you. Jan, you had a question?
Yes, thank you. Thanks, Susan, for being here. Could you speak a little bit about the quality and any issues relating to the data on race and ethnicity? Is this something that comes up as a concern in terms of similarity across data sources?
Yeah, so we try to do a lot of work on race ethnicity because it's such an important field.
Mhm.
And for NACER, at least for race, and I'm not sure if this has changed, but I don't think if your hospital is allowed to ask you race ethnicity. But we do a lot of researching other data sources. So our staff might have we have Social Security. I don't know what exactly is included in all that information, but say that's an example of what we might use. We go to obituaries, we go to motor vehicles. Yes, so that's how we try to get. And then we have, if we get 10 admissions and they're different races, we have to try to figure out what is the proper race. And we do collect a separate field for Hispanic identification. And one, NACER also runs an algorithm. It's called NAHIA, using Spanish surnames, but for Massachusetts, it doesn't work well. It overestimates our Hispanic population because we have a large Portuguese population. So we have our own Hispanic algorithm. It's called MA NAHIA, and it's just been incorporated in CRDMS.
Super. That's really interesting. Is there any conversation about expanding to multiracial identities? Or is that asking too much? I mean, it's already a lot from what you're describing.
We have, I think it's part of the selection under race. I'd have to go back and look. And you can also go to the volume 2 on the NACER website and search all the, the fields, and then you'll have all the information for every field. The name of the field and the data, the selections for that field. So I know that is more and more of interest.
Okay, great. Thank you.
Does anyone else have any questions? Okay. Thank you again, Susan. This was really, really
Oh,
great.
you're welcome.
Great source of information, and I think you'll have people who will follow up, either through me or
Our
directly.
data. Yeah, that's great. And, we do special requests. So if you're interested in a specific site, etc., we have epidemiologists that, are happy to run data requests for whatever you're interested in.
That'd be great. It's a wonderful resource. So thank you for coming today.
Okay, thank you.
Thank you.
Bye.
Bye.
Take care, Susan. See you.
Bye, Ruth.
Bye.